Hi, prostate problems is the subject of this video. This is a continuation of a series of videos designed to give individuals information that they can use to prepare for a visit to a physician's office. The videos are designed to help ensure that the individual can ask appropriate questions of the physician and to increase the likelihood that quality care is delivered. Let's talk a little about what purpose the prostate serves. Its primary function is to help sperm be healthy and active. It does not produce any hormones that impact a male's sexual drive. This is important for men to know. The removal of the prostate will therefore usually have no or minimal impact upon a male's sexual drive if the prostate is removed. The prostate is a walnut-sized gland situated directly below the bladder in men. The prostate gland produces fluid, semen, that nourishes and transports sperm. In this video, we will discuss prostatitis. The second video will discuss benign prostatic hyperplasia and carcinoma of the prostate. Prostatitis. Prostatitis is swelling and inflammation of the prostate gland. Prostatitis can be acute or chronic. Prostatitis can be painful and produce difficulty in urination. Prostatitis typically affects men aged 30 to 50, but can affect men well into their 60s and 70s. Prostatitis is usually caused by E. coli, Streptococcus faecalis, Pseudomonas, or Staphylococcus bacteria. Chlamydia can also be a cause of prostatitis, particularly a chronic prostatitis. Prostatitis can also occur without an identifiable bacterial cause. Prostatitis will usually present with fever, pain in the perineum. The perineum is the area between the anus and the scrotum. Pain in the back and suprapubic area, and symptoms of urinary frequency, urgency, and pain on urination may also be present. There may also be symptoms of bladder obstruction, such as a weak stream, hesitancy, straining, and a post-voiding dribble. A rectal examination may show a tender and swollen firm prostate. Post-voiding residual urine volumes should always be measured when a patient presents with prostatitis. The physician should always be concerned about possible obstruction problems. You should always ask the physician to measure a post-voiding residual volume. The objective, again, is to ensure that long-term bladder problems are avoided. If the patient has a temperature greater than 101.1 degrees Fahrenheit or 38.4 degrees centigrade, blood cultures should also be taken before starting antibiotic therapy. In young men, 35 years or less, who are sexually active, a culture of a urethral swab should be taken for Neisseria gonorrhea and Chlamydia trachomatis. In the elderly, the physician should order a complete blood count and a basic metabolic panel. A PSA level may also be ordered, but it is usually elevated in a case of acute prostatitis and will not contribute to the initial treatment decisions the physician has to make. Follow-up PSA levels will aid the physician to determine if treatment has been successful. Chronic prostatitis is something that must be diagnosed and followed closely. Failure to do so may result in severe bladder outflow obstruction. Chronic prostatitis is usually diagnosed by a history of mild voiding problems and the presence of perineal, scrotal, suprapubic, or back pain. In chronic prostatitis, the prostate gland may be normal on examination, but it is more likely that it will be boggy and tender when examined. Chronic prostatitis is difficult to treat. Again, post-voiding residual urine volumes should always be measured. If your primary care physician will not do them, demand a referral to a urologist and make the urologist measure post-voiding residual volumes. Treatment. Treatment of acute prostatitis is normally done with outpatient antibiotics. Less than 20% will require hospitalization for treatment. Hospitalization will be required for those who have failed outpatient treatment, those who cannot tolerate oral antibiotics, those typically ill, those who may be septic with bacteria in their blood, and those with urinary retention. Again, most patients will not end up with urinary retention problems if they are managed well, and post-voiding residual volumes are taken regularly. The duration of antibiotic therapy for mild infections is normally 10 to 14 days. For severe infections, the duration can be 4 to 6 weeks. If the patient has a fever which does not go down within 36 to 48 hours of antibiotic therapy, then imaging should be done to rule out a prostatic abscess. Prostate problems demand appropriate treatment, follow-up, and management. If you feel you are not getting that from your primary care doctor, then demand a referral to a urologist.